Usually when we look at a medical diagnosis, there's there's a certain expectation of mechanical precision, right? Like if you fracture your radius, the X-ray reveals this stark white line right across the bone.
Right, it's very visual.
Exactly. The physician just points to the film and says, there's the problem. It's visible, it's binary, and honestly, I mean, it's pretty comforting.
We do rely heavily on that sort of visual categorization in medicine. It provides a really clear roadmap for intervention.
But the moment you step into the world of regenerative medicine, that diagnostic clarity kind of it vanishes. We're looking at a landscape that is incredibly murky.
Yeah.
Where the things causing the most dramatic clinical emergencies are, well, they're entirely invisible. So welcome to another deep dive.
Yeah.
Today, we are opening up a massive stack of sources for you.
We've got clinic guides, immunology papers, medical journal case studies.
Yeah, and we're using all of this to solve a highly specific, really high-stakes puzzle. Our mission for you today is to nail down the exact clinical protocol when a patient experiences an acute, localized type hypersensitivity reaction.
And crucially, this reaction isn't to the cutting-edge regenerative treatment itself, but to the hidden chemicals used to prepare it.
Which is just wild.
It's a vital scenario to dissect. I mean, we are talking about the administration of exosome therapies here, which are rapidly becoming a cornerstone of tissue regeneration.
Right.
But as these biologics become more complex, understanding the precise mechanism of an adverse reaction is not just some academic exercise.
No, definitely not.
If a patient is on the table developing an acute hypersensitivity, knowing whether to reach for, say, an antihistamine or an autoinjector is quite literally a matter of life and death.
So to figure out how to stop a reaction, we first need to look at what is actually crossing the skin barrier, right?
Right.
The sources focus heavily on exosomes.
Yes, they do.
And they define them as microscopic extracellular vesicles, usually, between 30 and 200 nanometers.
That's right. They're extremely small.
Basically, they're these tiny phospholipid bubbles carrying a payload of proteins, RNA, and signaling factors. And an important distinction I caught in the clinical guides is that these do not contain live stem cells.
No, they are entirely acellular. The regenerative medicine community utilizes them precisely because they bypass the risks of introducing foreign living cells into a patient.
I found myself thinking of them like biological text messages.
I like that analogy.
Yeah, the exosome is essentially a delivery envelope sent from one cell, carrying this string of biochemical code that tells the receiving tissue to repair damage or reduce inflammation or build new collagen.
It's basically a cellular instruction manual.
Right, but here is the massive logistical hurdle I ran into while reading through the clinic protocols. The literature states these exosomes arrive at the clinic in a lyophilized state.
Meaning they were freeze-dried into a powder.
Right. But water expands when it freezes. So if you have this super delicate 30 nanometer lipid bubble full of liquid and you freeze it, wouldn't the ice crystals just physically rip the bubble apart?
Oh, absolutely. The biophysics of freezing biological material are brutal. Those ice crystals act like microscopic daggers.
Oh, wow.
Yeah, if they form within the aqueous environment of the exosome or even just in the surrounding fluid, they will pierce the lipid bilayer, completely shredding the vesicle and destroying the RNA payload.
So how do they even make the powder then?
Well, to prevent this catastrophic structural failure, the laboratories formulating these therapies have to engineer a chemical shield.
The cryoprotectants.
Exactly. The patents in our sources specifically list compounds like trifulose, methionine, and mannitol. These are blended with the exosomes way before the freeze-drying process even begins.
Okay, and what do those actually do?
They manipulate the thermodynamics of the fluid, effectively raising the glass transition temperature. This forces the liquid to transition into an amorphous, glassy solid without ever forming those lethal ice crystals.
Which leaves the clinician with a perfectly preserved, safe vial of exosome powder. But, I mean, you can't just inject dry powder into a joint for osteoarthritis or microneedle it into a face for cosmetic regeneration.
No, it has to be turned back into a liquid.
Right. The clinician has to reconstitute it.
Yeah.
And looking at the ingredient lists for prominent products mentioned in the texts, like anti-age or Benev, they aren't just using simple sterile saline.
No, they use a proprietary diluent.
Right. And the diluent is where the clinical risk profile suddenly shifts, doesn't it?
It really does. This is a complex chemical cocktail designed to optimize the delivery of the exosomes. It typically contains water, high molecular weight, hyaluronic acid for viscosity.
Sometimes tranexamic acid.
Yes, and critical preservatives to prevent microbial growth once the seal is broken.
And one specific preservative keeps popping up in all the literature: benzyl alcohol. This seems to be the smoking gun for the localized reactions we're investigating today.
What's fascinating here is that the human immune system completely ignores the regenerative exosomes because they are just natural lipid
Right.
envelopes.
They fly right under the radar.
Exactly. But it recognizes this synthetic preservative or other excipients like carboxymethylcellulose as a hostile foreign invader.
So how does the body actually detect it? Because the immunology of this recognition process is wild.
Yeah.
In the Gell and Coombs classification system, the scenario we are examining is a type I hypersensitivity, right?
Correct. It is an immediate, explosive immune response that relies on a very specific mechanism called prior sensitization.
Meaning the first time you're exposed to benzyl alcohol, you don't break out in hives. The body simply registers it.
Right. It takes notes.
Yeah. Since benzyl alcohol is basically ubiquitous, I mean, it's in everyday lotions, soaps, standard medical injectables, most patients have been exposed to it countless times.
So at some point, the immune system quietly categorizes it as a threat and generates immunoglobulin E, or IgE, antibodies tailored specifically to that one chemical.
It's like the immune system is printing microscopic wanted posters.
That's a great way to picture it. Those IgE antibodies then migrate through the body and embed themselves into the membranes of mast cells and basophils.
And those are like the overzealous security guards of the immune system.
Basically, yes. Mast cells are highly concentrated in tissues that interface with the external environment, particularly the dermal layers of the skin, the respiratory tract, and the gastrointestinal lining.
So the patient comes into the clinic totally unaware they have this latent immune trap just waiting in their skin. The clinician injects the exosome serum, which has been reconstituted with that benzyl alcohol diluent.
And then the benzyl alcohol molecules diffuse into the dermal tissue and physically bump into those embedded IgE antibodies.
But it's not just a simple bump, right? The physical interaction required to trigger the mast cell is incredibly specific.
It is. A single molecule of the allergen actually has to bind to two separate IgE antibodies simultaneously, physically pulling them together on the surface of the cell.
It's literally like a nuclear launch console where two keys have to be turned at the exact same time to initiate the sequence.
Exactly. That cross-linking of the IgE receptors triggers a massive influx of calcium ions into the mast cell, which completely destabilizes the cell membrane.
And boom.
Boom. The result is instant degranulation. The mast cell violently ruptures its internal storage vesicles, dumping massive concentrations of preformed chemical mediators, primarily histamine, directly into the extracellular space.
And because this happens in a matter of seconds, the physiological fallout is immediate. Histamine acts right on the local vascular network. It binds to receptors on the blood vessels, forcing them to undergo rapid vasodilation.
Meaning the vessels dramatically widen.
Right. And at the exact same time, it alters capillary permeability.
The tight junctions between the endothelial cells that line the capillaries physically pull apart. Blood plasma begins weeping out of the circulatory system and pooling in the surrounding dermal tissue. And it gets worse. Within minutes of this initial histamine dump, the mast cell ramps up a secondary phase, synthesizing and releasing newly formed lipid mediators, specifically leukotrienes and prostaglandins, which amplify and prolong the whole inflammatory response.
So if we map this microscopic chaos to the macroscopic symptoms on the treatment table, the rapid vasodilation explains that sudden, intense erythema, or redness, just flushing across the patient's face.
Oh, right.
And the fluid leaking out of the capillaries creates the localized edema and the raised, distinct erythematous wheals that we call hives.
Plus, the histamine actively irritating the nerve endings causes severe pruritus, that unbearable itching.
So now the clinician is looking at a highly visible, rapidly evolving acute reaction, and the physiology dictates the clinical response.
It absolutely does.
Which brings us to the core of our deep dive. So what does this all mean for the actual protocol? The physiology tells us exactly what chemicals are flooding the tissue, so how does the clinician counter it?
Right. The patient is lying there, their face is swelling, they are breaking out in hives.
I know my immediate instinct, heavily influenced by movies, honestly, to reach for the auto-injector and just hit them with epinephrine right away to be safe.
And that is a critical yet surprisingly common clinical error. Administering epinephrine for a strictly localized reaction is actually not indicated.
Really, no epi at all.
Not initially. The very first step before pushing any medication is a systematic primary survey of the patient's vital signs, the ABCDEs, Airway, breathing, circulation, disability, exposure.
Okay, so you're checking to see how far it's gone.
Exactly.
Yeah.
If the airway is entirely clear, breathing is completely unlabored, and the blood pressure is perfectly stable, you are dealing with a localized cutaneous event.
So injecting a massive systemic cardiovascular stimulant like epinephrine into a patient whose only symptom is facial hives, that just introduces severe unnecessary trauma.
You are risking profound tachycardia, dangerous spikes in blood pressure, and potential myocardial ischemia, especially in older patients. Epinephrine must be held in reserve for systemic collapse.
Okay, got it. So instead, we have to target the local vascular chaos. If the primary problem is that histamine is forcing the blood vessels open and making them leak, the most immediate physical countermeasure would be cold compresses applied directly to the injection sites, right?
Yes, the localized application of cold induces rapid vasoconstriction. It physically shrinks the diameter of the blood vessels.
Counteracting the histamine-induced vasodilation.
Precisely. Which significantly slows the fluid leakage and dulls the neurological signaling that's causing the severe pruritus.
But, I mean, the cold doesn't eliminate the histamine, right? It just fights the mechanical effect of it. Those millions of histamine molecules are still floating around in the tissue, aggressively locking into vascular receptors.
Right, they're still active.
So to neutralize the actual chemical signal, the sources outline immediate pharmacological intervention using antihistamines.
The clinical guides recommend administering H1 receptor antagonists. Depending on the clinical setting, this might be oral cetirizine or, for a much faster onset, intravenous administration.
Yeah, one of the perioperative case studies we've reviewed explicitly details utilizing 4 milligrams of intravenous phenyramine to rapidly occupy and block those histamine receptors.
Which is very effective for that initial wave.
Right, blocking the receptors stops the current wave, but earlier you detailed the secondary phase of mast cell degranulation, the newly synthesized leukotrienes and prostaglandins that hit minutes or hours later. Antihistamines don't do anything about those, do they?
No, they don't. That requires modulating the body's broader inflammatory cascade, which is why the protocol introduces a short course of corticosteroids.
Oh, okay.
The literature frequently cites 5 milligrams of intravenous dexamethasone or methylprednisolone.
But those aren't instant, right?
No, corticosteroids take longer to alter gene transcription and halt inflammation, but they act as a vital firewall against that late-phase allergic response, ensuring the hives and swelling don't just rebound violently the very next day.
Okay, so the patient is given the antihistamines and the steroids, the cold compresses are on, and the swelling actually begins to subside. But the protocols make it abundantly clear that the clinician does not just pat them on the back and send them home.
Definitely not. There is a mandatory period of intense, continuous monitoring.
Because a localized reaction is rarely static, right? The release of mast cell mediators is this dynamic, escalating cascade.
Exactly. If we connect this to the bigger picture, the clinician is essentially standing watch, monitoring for the exact moment the localized tissue response bleeds into the central circulation. They are watching for the tipping point into systemic anaphylaxis.
And the sources define that threshold very rigidly. Anaphylaxis is clinically diagnosed the moment 2 or more organ systems become involved.
Yes, 2 or more.
So if that localized swelling on the face is suddenly accompanied by respiratory compromise, say the patient starts exhibiting severe wheezing or stridor, that high-pitched sound of a narrowing airway, the diagnosis changes in a matter of seconds.
Alternatively, the secondary system could be cardiovascular. If the vasodilation stops being a local facial issue and suddenly occurs systemically across the entire circulatory network, the patient will experience a precipitous drop in blood pressure.
The clinical threshold noted in the sources is a systolic blood pressure falling below 90 millimeters of mercury.
The moment either of those thresholds is crossed skin plus respiratory or skin plus cardiovascular, the conservative localized protocol is immediately abandoned.
And that is the exact moment you grab the epinephrine.
Yes, it is the definitive, non-negotiable first-line treatment for anaphylaxis. The standard adult protocol dictates 0.3 to 0.5 milligrams of a 1 to 1,000 concentration administered intramuscularly.
And the injection site is critical here. The guidelines specify the vastus lateralis, the lateral aspect of the thigh muscle rather than, the deltoid in the arm.
That's right.
I'm assuming this has to do with the sheer vascularity of the leg muscles, allowing for a much faster systemic absorption of the drug.
Exactly. The vastus lateralis provides the most rapid and reliable pharmacokinetic profile during a circulatory crisis. Once in the bloodstream, epinephrine acts as a powerful alpha-1 agonist, violently constricting the systemic blood vessels to force the blood pressure back up.
And it hits the lungs too, right?
Yes, simultaneously, its beta-2 agonist properties act directly on the lungs, relaxing the smooth muscle tissue to physically force those constricted airways open.
Man, it really is a miracle drug.
Yeah.
But while the epinephrine is fighting the physiological collapse, the team is executing vital adjunct therapies too. The positioning of the patient changes immediately to the Trendelenburg position.
Right, supine, flat on the back with the legs significantly elevated.
Because if massive systemic vasodilation has caused blood to pool uselessly in the extremities, elevating the legs leverages gravity to force that venous return back to the heart and the brain.
You're also fighting profound tissue hypoxia, so the protocol requires applying high-flow oxygen, typically 15 liters per minute via a non-rebreather mask.
Okay, got it.
And crucially, establishing large-bore intravenous access to rapidly push a 1-liter bolus of normal saline.
Right, because even though the patient hasn't physically bled, they are suffering from distributive hypovolemia. The fluid has leaked out of the capillary so severely that there simply isn't enough volume left inside the vessels to maintain pressure, even with the epinephrine trying to constrict them.
Exactly. The fluid bolus physically refills the vascular space. Now, once the patient is stabilized and the vitals return to baseline, the immunology literature issues a really stark warning. The patient must be transported to a hospital for prolonged observation. They absolutely cannot be discharged from the clinic.
Because of the biphasic response.
Yes.
This is a terrifying phenomenon documented in the sources. Between 1 and 20% of clinically resolved anaphylaxis cases will feature a secondary, entirely unprovoked recurrence of the life-threatening symptoms anywhere from 1 to 72 hours later.
It's a huge risk window.
Right. The initial wave of histamine is countered, but a delayed massive synthesis of inflammatory mediators triggers a second systemic collapse without any new exposure to the diluent or the exosomes.
It necessitates intensive care monitoring because the second wave can often be more refractory to epinephrine than the first.
Okay, so let's look at the aftermath. Assuming the patient navigates the acute phase, whether it was managed locally or required the full anaphylaxis protocol, the clinical emergency ends. But a massive diagnostic liability basically begins.
Oh, definitely.
The medical team has to definitively prove what caused the reaction. Was it the regenerative payload of the exosome? Was it the hyaluronic acid? Or was it the benzyl alcohol preservative in the diluent? Here's where it gets really interesting for you diagnostic fans out there. How do doctors actually confirm the culprit?
Well, identifying the culprit requires precision diagnostic workups, typically managed by an allergist. After an appropriate recovery period, the patient undergoes skin prick testing and intradermal tests.
Okay, and what does that involve?
The allergist uses highly diluted, isolated versions of the specific excipients from the diluent, exposing tiny regions of the dermis to map out exactly which chemical provokes a localized wheel and flare immune response.
But the literature provided a brilliant case study demonstrating that in the real world, this diagnostic detective work can fall into a gray area that just completely defines expectations.
Yes, that case study was fascinating.
The paper detailed a 48-year-old female patient undergoing maxillary sinus surgery. As she emerged from anesthesia, she developed massive facial angioedema, severe, disfiguring swelling of the facial tissues, accompanied by subjective laryngeal discomfort. She was actively feeling her airway narrowing.
The clinical presentation was textbook anaphylaxis.
Right.
The surgical team responded flawlessly, utilizing the exact systemic protocols we just outlined: intramuscular epinephrine, intravenous dexamethasone to halt the late-phase inflammation, and phenyramine to block the histamine receptors. The intervention succeeded, and the patient stabilized.
But the ensuing immunology workup yielded impossible results. When an IgE-mediated mast cell explodes, it dumps histamine, sure, but it also releases an enzyme called tryptase. In modern immunology, serum tryptase levels are considered the gold standard biological marker to retroactively confirm that a true allergic anaphylactic event took place.
Right.
So they drew her blood, fully expecting the tryptase to be wildly elevated.
But her serum tryptase levels returned completely normal.
Which is crazy.
They subsequently ran assays for C1 inhibitor levels, testing for an alternative pathway of swelling called bradykinin-mediated angioedema, which operates entirely independently of mast cells. Those levels were also perfectly normal.
So how does a clinician reconcile that? The patient suffers massive, airway-compromising facial swelling. responds perfectly to the administration of epinephrine and antihistamines, but leaves behind zero biological markers in the blood, proving an allergy actually occurred.
It is documented in the literature as a seronegative reaction, and it really exposes the limits of our diagnostic testing. There are a few mechanisms that explain this.
Okay, let's hear them.
In highly localized reactions involving the dense tissues of the face and throat, the mast cells absolutely degranulate, but the tryptase released into the interstitial fluid fails to diffuse into the central venous bloodstream in high enough concentrations to trigger a positive serum test.
Ah, okay. The sources also point to the possibility of pseudoallergic mechanisms, right?
Yes.
This is where a specific drug or chemical excipient possesses the biochemical ability to directly destabilize the mast cell membrane, forcing it to rupture without ever utilizing the whole IgE cross-linking pathway we talked about.
Exactly. The clinical symptoms are identical. The vasodilation, the fluid leakage, the airway compromise, and the mortal danger is identical, but the classic laboratory signature is missing.
The seronegative case study is arguably the most profound lesson in acute allergy management found in these sources.
This raises an important question regarding diagnostic markers. It dictates that clinical judgment and strict protocol adherence must universally override the wait for laboratory confirmation.
Yeah, if you are a clinician and the soft tissue of the patient's face is expanding and their airway is narrowing, you execute the anaphylaxis protocol based entirely on the clinical reality unfolding right in front of you. You treat the patient, not the test tube,
Well said.
which fundamentally changes how both clinicians and patients need to approach these therapies. Whether you are walking into a clinic for a cutting-edge cosmetic exosome treatment, receiving a routine corticosteroid injection for orthopedic pain, or you are the medical professional preparing the syringe.
Understanding that the inactive ingredients, the preservatives, the viscosity agents, the lyophilization shields harbor the true hypersensitivity risk alters the entire intake process.
It requires a far more granular medical history, doesn't it?
Absolutely. A patient might confidently state they have no allergies to biological therapies, completely unaware their immune system is primed to react violently to the benzyl alcohol used to reconstitute the vial.
It really empowers you, the listener, to scrutinize the packaging, not just the primary drug. Which leaves us with a rather unsettling thought to carry forward. We have spent this entire deep dive meticulously breaking down the physiological cascade of an acute immune response to a simple diluent.
Yes, we have.
We know the mechanical protocol to halt that histamine-driven vascular collapse in a matter of minutes. But the primary payload we started with, the exosomes, aren't simple chemicals. They are complex biological text messages carrying RNA and signaling proteins designed to actively reprogram cellular behavior for weeks, if not months, after the injection.
The acute Ig-mediated reactions are dramatic, terrifying events, but they are highly visible and, as we've discussed, clinically manageable.
Exactly. But what if the most profound, disruptive side effects of this new frontier of regenerative medicine aren't the acute, explosive hypersensitivities that we can instantly neutralize with a shot of epinephrine? What if the true risks are silent, undetected, long-term cellular miscommunications, errant RNA instructions, causing subtle genomic shifts that we won't even possess the diagnostic tools to understand for another decade?
It forces us to acknowledge that while we have mastered the emergency response to the delivery system, we are still largely blind to the long-term biological consequences of the payload itself.
The X-ray machine is definitely broken when it comes to regenerative medicine. But as the protocols we explored today prove, we are constantly developing new ways to navigate the dark. Thank you for joining us as we work through this clinical puzzle. We will be back to dive into another stack of sources with you very soon.